Welcome to Residency Hot Topics. Thank you all for joining us on a Tuesday night. We are in luck. We have an absolute world class presenter. Saw him at CSM in February. He was gracious enough to agree to join us on this forum. One of the most prolific sports practices in the United States, and he is the co founder and director of PT. Leading us through an ACL rehab masterclass, Lenny Macrina. Floor is yours.
All right, thank you, Ben. Thank you everyone for tuning in tonight, and for those that are going to watch it later on, thank you in advance. We'll hit upon some of the big topics in ACL rehab, and hopefully we can have some questions at the end to kind of mix all that in. But it's just kind of my overview of ACL rehab. It's only a 45-minute talk, so we'll get through it and try to hit some of the big points and what's in my head and what's out there for ACL rehab. So let's begin. So we know ACL rehab or ACL surgeries are very common. This is kind of that opening line that's in every single journal paper you ever read about ACLs, right? And it's oftentimes going to be that non-contact deceleration with a twisting type injury, right? It's usually not that contact pushing type injury. It's probably about 2/3 are going to be your non-contact injury. And unfortunately, as much as we are scientifically based and we try to design a good program for patients, the research is all over the place, and we'll hit upon some of that coming up. But as much as we think we know, we really don't know. And not much has changed over the last 25 years or so, believe it or not. I think we've actually gotten more conservative in what we do than what we used to do in PT. So maybe we'll hit upon some of that as well. We know when you tear your ACL, it's a big injury, right? You tear your ACL, but it's all the other stuff that goes on, right? So you think about tore my ACL, I got to get a ligament replacement. Well, that's just a small portion of what's going on because it's not an isolated injury. Most oftentimes, I'd say greater than 50%, 65% sometimes, there's a meniscus tear as well. And that also has to be addressed through a meniscectomy or some kind of repair. And then it depends on the type of repair that they have to do. That could affect the rehab as well. So when they repair the meniscus, whether it's a vertical longitudinal repair or even worse, a root repair, which is in the back of the knee as it attaches to the capsule, that can be significantly limiting during the ACL rehab process. You got to communicate with your doc because that's also a huge portion of what's going to affect how quickly we can progress them and get them weight bearing and stuff like that. I tend to disagree most times with our doctors. And if you follow me on social media, I have a pretty strong opinion that people should be more weight bearing earlier on and no limitations in their motion for most of the repairs. But we got to go along with the surgeon. So again, have a good understanding of what was done in the surgery for the meniscus, because there's also going to be probably a bone bruise as well. So when you have that typical ACL tear, that deceleration, twisting, rotation type injury, you get a lateral bone bruise, lateral meniscus tear, along with the ACL tear. That's going to be your most common locations. You will sometimes see a medial meniscus as well, but the lateral meniscus, in my experiences, has been more common than the medial meniscus. So the bone bruise is, in some studies, highly prevalent. In some studies, even 100% prevalent in their ACL findings. So that could also affect us, meaning swelling, future arthritis in the knee could also be as a result of the bone bruise. So when that persistent swelling kind of settles in, it's oftentimes due to the bone bruise that is still there and probably there for months and months and months, longer than we think. And so you got to kind of respect that too when you're initiating your plyometrics and things of that nature, the higher impact stuff, and that swelling comes back quickly or is persistent. It might still be that underlying bone bruise that is highly, highly prevalent in our ACL patients, right? So all had a bone bruise. It can affect their knee long term, 5 to 7 years post-op after surgery. In this study, this is that Potter study I just had up. Chondral degeneration can occur, and 10 plus years out of their ACL injury where they do have a bone bruise, you're going to see cartilage loss in the lateral femoral condyle, the patellofemoral joint, and also in the medial femoral condyle as a result. So we gotta be, I guess, aware, and we also have to take this into account when we're progressing our patients, right? Because long-term implications are a higher rate of OA of the knee, in this 2019 study, it showed a six times increased risk of knee OA. A lot of us are going to eventually develop knee OA, whether it's metabolic or whether it's an injury, but having an ACL tear had the highest, proportion of subjects that developed knee OA was the patients that had a cruciate ligament tear with a reconstruction. So never mind when we're talking about the basics of what went on, so ACL, meniscus, bone bruise. There can be other stuff too. We have an MCL, an LCL, ALL. The different sites of the meniscus tears that can occur, but you also have the issue with female athletes, and we know that this. I think I just put in my Instagram a couple weeks ago. I happened to just look in our clinic what was going on, and we had, I think there was 5 females, a couple students, and were included in those 5 females, and there were 9 total ACL tears amongst those 5 female, whether it was a patient or a PT student. So 4 of them had 2 ACL tears, and 1 of them had 1 ACL tear. So there's 9 total ACL tears. So we know that it's more prevalent in females. There's numerous theories out there as to why, but it's definitely at a 4, 5, 6, 7 to 1 tear rate than males, unfortunately. And so what can we do to help all that? There's some programs out there, the PEP program, the FIFA 11 program, or whatever we're calling it now, the FIFA program is out there, and we build that into our strength and conditioning programs for our athletes. We don't call it's an ACL prevention program. We just call it a strength and conditioning program. Whether it's teaching them how to jump and land, whether it's teaching them how to just getting stronger and showing the proper weight training techniques and periodization, all that stuff is going to lend and be a benefit to the female athlete, especially because of the higher rate of re-tears. Because we know if female soccer players after an ACL reconstruction have a 5 times increased risk of a new knee injury than a healthy control. And that was a study that came out about 8 years ago. So we know that if they have that initial injury, that ACL tear, not only are they more likely to tear their other side, their other knee, but they're also more likely to have a new knee injury in general. So it's devastating. It's devastating to their career. I can't tell you how many female athletes, I got a couple right now I can think of actively in our clinic, not just the students, but just in general, who've had one and then a second one, 2, 3, 4, 5 years later. I have one just had 8 years later, so not even related to her first one, potentially, was playing club lacrosse and tore the other side after tearing it when she was 14 years old. So it's out there, unfortunately, and that's the number one risk to re-tearing, is having that initial ACL tear. This is always a hot topic on social media, right? What graft to choose? This gets people fired up. It's so funny to talk about this stuff on social media because everybody's got an opinion. Everybody works with a doctor who they trust. Everybody they have their biases of who they think or what they think is the best graft. I'll tell you what, I'm not biased and I have my opinions. I am very biased. But I think patella tendon, if you follow me on social media, you know my opinions on graft choice. They're all stronger than the native ACL, right? So what you were born with and what they're going to put in is stronger than what you had. So that's not the issue. It's just a matter of how it fits that person's life, how it's going to fit that person's ACL rehab course, what are the potential, known complications or known issues that may come about. And those are the conversations that you have with the patient. Hopefully pre-surgery, that prehab class or prehab session that you have with them, those are the conversations that you have, right? Patella tendon has a little bit more anterior knee pain, and that some would say, and some would say that's the reason why to not do a patella tendon graft. I completely disagree. I think if you manage them appropriately, and periodize a program for them and monitor their anterior knee pain, and every visit I'm palpating patella tendon, I'm palpating joint line, I'm monitoring swelling, and especially monitoring their knee extension. I think that is a huge contribution to anterior knee pain. Is if we don't get that full knee hyperextension back, they're always putting pressure through that anterior compartment, that patellofemoral joint. They're always going to be stressed in that area. So you have to get the hyperextension back, and we'll talk about that in a second. So if we can get all that back and monitor it, I think the patella tendon graft is a superb choice. We have about 50 years of data on it. This has been going on since the 70s, the patella tendon graft. So, in some of the newer I know hamstrings are big in Europe. Quad tendon grafts have made a resurgence back. They were big probably 10 or 15 years ago, kind of went quiet, or even longer than 10 or 15 years ago, probably 20 years ago, and kind of became quiet, and now it's back again. The past 5 or 10 years, quad tendon grafts have really come on strong, and people are pushing for them. I think there's, some reasons out there that quad tendon grafts are being pushed. I'm not going to get into that. I've had some discussions on social media. You can follow my Twitter or X feeds if you want to kind of dive into that. But it seems like quad tendon is a viable option. It's a very robust tendon, but I think it just takes longer for that quadriceps muscle to come back. And there are some papers that show that than in other grafts, especially a hamstring and especially a patella tendon graft. So you got to understand all of that. So again, you have your patella tendon, hamstring, quad tendon, and don't worry about any other types. I guess allografts too, cadaver grafts. That might be appropriate for an older population. I think I touch upon that in the next slide. So again, the gold standard is going to be your patella tendon graft. That's going to be your athlete. The NFL, I think about 95% of NFL players have had a patella tendon graft. There's a reason why. We know the most about it. It's the most predictable graft. It's a very strong graft. You can see in the picture, in the bottom right, it's a bone, patella tendon bone. So you have bony fixation up into the femoral condyle, up in the femoral tunnel, and you have a bony fixation down into the tibial tunnel. Very strong. Blood flow is going through that bone into the patella tendon. You get ligamentization, I think, a little easier, where the tendon becomes a ligament with that bone interface versus a hamstring graft or a quadriceps graft, where you don't have that bony interface in most instances, and you just have a soft tissue graft. So there is some stretching out that can occur, especially in a hamstring graft compared to a patella tendon graft, and you have a more robust quadriceps graft that can lead to some knee extension tightness, and like I mentioned earlier, some lack of quadriceps strength in some people, depending on who you talk to. I'm observing that as well. In patients that have had quad tendon grafts, I struggle to get their strength back. Absolutely struggle. And I've been doing this for almost 25 years, and I've never seen anything like it, where 9, 12 months out of surgery, 15 months out of surgery. I have one kid right now. I think he's about 20 or 22 months out of surgery, and his Biodex tests are still like 70%. It's a tough go. And so I am educating my patients. I'm a patella tendon guy. I have been, and I don't know if I'll, kind of change it that. There is the bear procedure as well. I wanted to introduce you to that as well, where the basically you tear your ACL, the two ends. You tear the ACL mid-substance, and you can kind of reattach it back with this procedure, in which blood from the patient is put on this sponge-type device, sewn into the tears, and it helps to regenerate, the ACL and the fibers back intact. So you don't have to have a reconstruction. It's essentially, it's a repair. Essentially, it's reestablishing the two ends of the ACL back together. It's a very neat concept. I think more research is needed. There is a paper that has shown similar results to hamstring autografts. I haven't seen anything that compares it to patella tendon autografts. That to me would be eye-opening if it was similar retear rates. I think we need more data on this, but I wanted to talk about the bridge enhanced ACL repair, or the bear procedure, that you may run into. The rehab is very slow at the beginning. Range of motion is slow. Strengthening is slow. And then by about 6 to 8 weeks, you're off to the races. And then by 3 months, it turns into a regular ACL rehab. You got to let those first, 6 to 8 weeks, you got to let that interface, that blood interface, that sponge-soaked blood interface kind of, I guess, establish itself. And so the first couple months are relatively slow, and then it's all right, off to the races with strength and conditioning and strength training. So it's an interesting kind of scientifically advanced concept that I think we need more data on. So that's, again, the bridge procedure. Okay, so it showed similar outcomes with patients in lower pain rates, because they're not taking any tendon out, they're not drilling any tunnels in your bones. And so, it's hopeful, but I think, again, we need more data on this. So no difference in re-injury rates at 24 months. But again, the gold standard is going to be your patella tendon graft. Your semitendinosis, I think it's the hamstring graft is kind of I guess it's a very regional thing. Um, it's very big in Europe. Some doctors in America are still doing it. I would not recommend this for, I don't know, your young female, the higher, the high rate of ACL tears, that young female, I would go patella tendon, but your hamstring is a viable option as a revision graft, or somebody with open growth plates, or an older patient, that 35 plus, who's looking for an autograft, who doesn't want to, go through the patella tendon graft. It's still a painful surgery. You're not gonna have as much loss of quadriceps function as with the patella tendon or the quad tendon, but you will lose hamstring strength because they're taking your hamstring tendon or tendons out. And so you don't grow those tendons back. There will be some pseudo tendons that may appear on an MRI, but you will have some potential long-term loss of hamstring strength. So if you can handle that and the potential for a little bit more laxity in the knee, a couple millimeters extra laxity because of potentially, that there's no bony interface that we talked about earlier on the patella tendon graft, then a hamstring graft might be for you. Again, it's that active person who's not going back to, college soccer or high school lacrosse. It's that person who's trying to be active, maybe skiing, who can afford to have a weaker hamstring and maybe a little extra play in the knee than your gold standard patella tendon graft. We talked about quadriceps tendon. Again, it's becoming more popular. It's becoming more difficult for me to understand why it's becoming more popular. Most doctors don't really take a chunk of bone from the patella, like is mentioned on the screen. So it's just a soft tissue graft, but it is a very big, robust graft. And it's depending on. I've talked to many surgeons. I talked to a lot of people on social media. It seems like depending on how much graft they take out, it's more of a rectus femoris tendon is the superficial portion of the quadriceps tendon, which means you need to really work the rectus femoris afterwards. And we'll talk about that in a little while and how I do that. The deeper layers that they take, I think, tends to lend to more long-term quad weakness. And then I think if they just leave the interval open versus closing where they took the tendon, seems to be a factor that is causing a stretch out of the quadriceps tendon and leading to long-term issues in strength training and strength abilities, I guess. And so it's all over. I see some people talk to me and DM me that they have no issues getting the strength back after quadriceps tendon, and some people completely agree with me that it's a struggle. And so I'm still trying to figure out why this is happening, why it's not as predictable as a patella tendon, why it's being sold so much as, the next coming of whatever, that it should be replacing patella tendons from any of our athletic population. And I'm still confused why, because I'm not seeing the overwhelming positives of it. Okay. So it's a smaller graft. It is, just superior to the patella. And it's a very, like I said, it's a big old graft. Allografts, I still see some. I see a lot of ACLs that, yeah, eye roll emoji. But I do see some in the older population, that 45, 50 plus, who is maybe going back to recreational skiing or just wants to go play pickleball or something like that. A lot less pain, a lot easier to get their strength back. Despite, that 45, 50, 55-year-old, female, which is what I typically see the skier. Long term, a little extra play in the knee. Re-tear rates are higher, especially in the younger population. So we used to do allografts and tried to do allografts on that, 15, 20, 22-year-old athlete, and the re-tear rates were through the roof. And so it was sold as less pain, quicker return to sport, and it turned out to be completely wrong because the tissue is not your own tissue. It takes longer for it to integrate into your body, and sometimes it doesn't integrate into your body, and your body will actually chew it up and spit it out. And some people have, had a very small, misstep or something, and then they're like, "Ooh, that felt funny." And their knee swells up. They go to the doctor. They get an MRI, and there is no ACL even present in their knee. Whenever they had that reconstruction with the allograft, the body just basically saw it as a foreign substance, and just chewed it up, had an immune response. And so there was no ACL. And so there's no remnants of the ACL. It's very interesting to see that. And so we reserve the allograft again for that lower activity, older population who can't dedicate rehab as much as the younger population. So their strength comes back and they still have a somewhat functional, stable knee. Okay. I think a lot of what we talked about is in the graft choices all comes down to revascularization and this tendon. Remember, it's a tendon, it's a patella tendon, quad tendon, hamstring tendon, revascularizing to become a ligament, so ligamentization, to resemble a native ACL and the properties of an ACL. And so there's not a lot of good research out there. A lot of it is in animal studies, but you will see if you look at this slide for maturation to occur, you're looking at 21, 24 months where maturation occurs in the graft. We don't have that much time with our ACL patients, right? We're looking at 9 months return to sport in some of the research. I think that's, I think we're starting to debunk even the 9 month thing, but 9 months is a rough beginning point. It's better than what we used to do, which was 4 to 6 months return to sport. I can't tell how many athletes I got back at 4 to 6 months, which is crazy to think about. I don't even know how they're doing long term, but we were doing that. Now we're up to 9 months as like a time frame when we're educating our families before and slightly after surgery. And so I think revascularization and maturation of the graft is huge. And that's probably why one small reason why, and you talk to somebody like a Tim Hewitt, who's a big researcher out of Marshall University, I think he's at now, talks about the 2 year, let's wait 2 years to return to sport. Not possible. Picture, Tommy tears his ACL his junior year and he's not going to get back to his sport until, end of his senior year, freshman year in college. That's not going to happen. He's going to miss out big time on trying to get into a school and play his sports. But I think waiting 9 to 12 months and understanding that the maturation is still occurring is good for us PTs to know and athletic trainers to know. So keep that in mind. That it takes a lot longer than what we're doing right now, and could be one small reason why our re-tear rates, despite everything we know about ACL rehab, our re-tear rates are still crazy high, right? Crazy high, especially if they've torn it, once and have in the re-tear rates. But I think in general, 15, 20, 25% of our ACL patients are going to re-tear, which is just frightening. So for those that have not worked with an ACL patient, this is your classic look. That's that, first day out of PT or first day out of surgery and going to PT. It's a bloody mess. This is a quad tendon graft I saw years ago. And yeah, this is what we sometimes have to deal with, glove up and hope, get the patient to lie down, right? We don't want them to pass out. So put them on their back and let them look at that when they're ready. And, you slowly pulling layers off to get to the incisions and making sure everything is clean and you're reassuring that everything looks good and everything's normal. It looks a lot worse than it is. Once you get all this off, you're like, that's not that bad, right? It's just like a couple incisions and all the blood was soaked into the gauze. So yeah, that's what we're dealing with. Is that's a superior at the top. You can see up right there at the top that's the quad tendon, and then the scope holes are how the working portals to get the graft, reconstructed. And then we talked about other structures that could be involved too. Remember, we talked about meniscus, we talked about bone bruise, and then all the other structures too that will influence, how we're going to rehab the person. LETs, lateral extra-articular tenodesis, is being done as well. You might see a lateral incision just superior and lateral to the patella. That's going to be just basically taking the middle portion of the IT band and kind of cutting it out and then kind of rerouting it to the lateral condyle and then tacking it down there to kind of give extra stability, rotational stability to those higher risk, patients. The female, the patient that has a lot of hyperextension, that 10 plus degrees of hyperextension in the knee, these are people that are going to have an LET, lateral extra-articular tenodesis. You're also going to hear ALL repair, so anterior longitudinal ligament. That's oftentimes torn. It's just a thickening of the lateral capsule. They'll sometimes try to repair that as well. Not as easy to do because it's just a thickening of the capsule. It's not as easy to find. So I'm seeing a huge kind of push towards this LET as that extra incision, extra portion of the surgery, the extra stabilization of the knee to help prevent ACL tears long term. So kind of look at that as well. In our patients, we mentioned this earlier, loss of knee extension is huge. It'll change the arthrokinematics of the knee. It'll change the ability for the quadriceps to contract, and it's going to lead to, I think, long-term issues in the knee, just long-term arthritis of the knee, pain in the knee. So you got to restore that knee hyperextension back. Donald Shelbourne out of Indianapolis talks about this in his paper, that even a loss of just 3 to 5 degrees, let me go back there, even a loss of just 3 to 5 degrees can affect a patient's long-term, I guess, function. And so when doctors and some PTs will say, nah, you just need to get 0. If they have 5 degrees of hyperextension on the unaffected side, and you just get them to 0 on the surgical side, you're just giving this patient an excuse to not do well. That's on us. We need to get that hyperextension back and restore it to symmetrical to the other side. If they have 10 degrees of hyperextension on the other side, well, A, you hope they had an LET because that seems to help with the re-tear rates. But B, they're a hyperlaxed patient, so they have a higher chance of a re-tear. I wouldn't get the 10 degrees of hyperextension back right away, but I'm eventually going to get it back over the first 4, 6, 7 months out of surgery. I'm going to probably get a few degrees of hyperextension immediately, hopefully, and then slowly build functionally to get the rest of the hyperextension back because they need to. If they just lose a few degrees, again, they're going to compromise. You're going to compromise the function of the knee, and they're never going to feel right. And I think this is a huge reason why that anterior knee pain persists in some of our ACL patients. So again, mobilize the patella. Must have good patella mobility in all directions. You don't want to get infrapatellar scarring. Fat pads. They go through the fat pads when they do the surgery, so they tend to get scarred down. You have to mobilize the patella multiple times a day. You are doing it every session in PT, and you have to educate your patient or the patient's family to do this. I think there's a critical aspect that is overlooked, and it's a small detail that we could avoid so many issues with some of our patients, especially in our patella tendon grafts, if we don't mobilize the patella enough. And I think people take for granted this little basic detail, and I think you have to really educate your patients and the families to get this kneecap moving. It's kind of funky for the person to do it to themselves, but if you can get a family member or somebody to do it, or the person gets comfortable doing it, it's a huge factor in helping people get back. Old school Lenny from down in Birmingham, Alabama, when I used to work with Kevin Wilk, but this is how we just do it. I'm not a big prone hang guy. Some people still do it fine. I've never really done prone hangs. I feel like you get the hamstrings contracting, you get their pelvis is all out of whack. They're fighting their knee from going straight. It's not a comfortable position. The legs hanging off of a table or a bed. It's just so awkward. So I'm a supine, just prop them up, put an ankle weight above their patella, and then just let gravity kind of pull it straight. Have some space for the calf so it doesn't hit the table. So keep propping their ankle up. And they're doing this right away after surgery. And this is something huge that I think helps restore that knee hyperextension as well. That bottom slide or the bottom picture is the extensionator. From ERMI. I think they're out of Atlanta, Georgia. It's a device that's out there, but you can see the similar concept. There is a little wedge so the foot doesn't rotate out when you're trying to work on that hyperextension, but just prop something up, have them do it on the couch against, their foot against the top portion of the couch, and the foot won't rotate out. So there are devices out there that can do it. That was the ERMI, the extensionator back in the day. So again, we always blame the hamstrings. Yeah, the hamstrings are probably somewhat involved, but I also think it's the posterior capsule. This study looked at posterior capsule limitations after mobilization, and most likely culprit was the posterior capsule. So you got to get that stretched out as quickly as possible. Knees immobilized beyond 2 weeks fail to recover posterior capsule length. So in those docs or those patients that don't start PT until 2 weeks out of surgery because the doc wants to save visits or wants to wait to get that first post-op visit in to look at the wounds. They don't trust their PT. The PT, I don't want to get an infection. Don't go to PT yet. They're setting our patients up for failure because you're already starting to get some changes in the posterior capsule in those first 2 weeks. So I like a lot of motion. I like early motion. This is our old clinic back in the day, old student, just bending the knee. I'm a at the edge of the table knee flexion kind of person. I do this all day, every day. Each patient gets 2 sessions of this. They get a session after patella mobs. They get this at the beginning of the session, of the PT session. They do their exercises, whether it's leg raises, mini squats, whatever they're doing, and then I'll reassess more patellar more passive motion at the end of the session. Everybody gets 2 of these. I think it's hugely beneficial. I can kind of assess the knee, and oftentimes it loosens up after the session. So they come in, they're a little stiff. You do some motion, get them to 85 degrees of flexion or whatever. Do some exercise, get some of the swelling out by doing quad sets and leg raises. Do another set of bending after the patella again, and next thing you know, they're at 92, 94, 95 degrees of motion, and they're feeling good leaving the session. So 2 sets of motion, motion helps with pain, helps with swelling control. I'm also a big fan of CPM. I know that's kind of old school, but we have a couple of docs in Boston that still use a CPM, and I'm a big proponent of it. I think it helps immensely in getting people's pain under control quickly and the fear factor of moving the knee. They'll get a CPM, first day out of surgery, they're in the CPM, getting it to 50, 60, 70 degrees of motion. And then they see me that first visit, 3 to 5 days out of surgery. And they're cruising. They're already at 90 degrees of flexion because they've already had the knee moving. They're taking fewer narcotics and they're just feeling good about how the knee feels in general, and they're not fearful of the motion. So I don't know. That's just me with the CPM, but I've seen very good things with it, and it's not very expensive. It's a couple $100 for a couple of weeks to rent it. Weight bearing. Most of our patients are going to be weight bearing as tolerated. Again, it's MD preference. If there's a huge bone bruise or a fracture or a meniscus repair, doctors, as I've mentioned, have gotten more and more conservative with these, where there'll be a toe touch weight bearing, or I've still seen some non-weight bearings, which just blows my mind that this is still out there. In the root repairs, where it's the back of the knee, where the meniscus attaches to the tibia and attaches to the posterior capsule, doctors are very conservative with this. There's a paper that just came out out of, where is he? Out of Missouri, that showed that the forces going through a root repair can, by weight bearing and by motion, it can withstand it. And so we may see I guess, some lifting of the very conservative guidance, hopefully in the next, few years, where we can treat a root repair similar to a meniscal repair, where we can get motion going a little earlier. Again, that 90-degree limitation is going to be there for most of the meniscal repairs, and the weight bearing precautions are going to be there. And so kind of, keep observing this and keep looking for this in the research, because I think hopefully in the next few years we can get a little bit more guidance that's a little bit more research based to help progress things along. But typically, if they don't have repair, the weight bearing is tolerated, brace locked. Some doctors don't even use an ACL brace. I don't know what's going on here. And so doctors aren't even using ACL. Very regional again. A brace versus no brace immediately out of surgery. So it's very interesting to see. There we go. Okay. What's the strain on the ACL? Very minimal, right? So you have the old school thinking not to do any open chain stuff for a while. I think that's kind of lifting now. It was just do 90/40s for three months. Now it's, knee extensions are safe. Open chain knee extension is good. It's functional. It used to be it's not a functional thing. You just got to work on squatting, blah blah blah. It's so interesting to see the evolution, or the what's the word I'm looking for? Kind of the return of old school thoughts back into the norm. But you can see from the really good paper, and if you're in a residency, hopefully this is one of the go-to papers when you're talking about ACL rehab. Rafael Escamilla kind of summarized, a lot of studies that are out there that showed the strain on the ACL is very minimal with a lot of stuff that we do. Single leg squats and bicycling, and even open chain knee extensions, and mini squats and stair climbing. Very low amount of stress. You can see here it's, less than 4% for most of the activities that we do. And so what's a critical number? It seems like 15 to 20% strain on an ACL is what causes an ACL tear. And so, these numbers are very low. Now, there was a paper that came out probably about 5 or 7 years ago that showed a 13% strain on the ACL with walking. It was a serial MRI type study that looked at, the change in length of the ACL, and it was kind of eye opening that 13% strain on the ACL with walking. And so in my head, it doesn't make sense, because if you're going to tear your ACL at about 15 to 20%, that means we're almost basically tearing our ACL with every step that we take. So I don't know. That paper, I respect the researchers. I've talked to them, and it's still mind blowing that 13% strain on the ACL with walking. So again, peak strain is again less than 4% for mostly everything that we do. Mini squats and stuff like that. Depending on the knee flexion angle, you can see about 4% strain with an active flexion to extension to open chain, and it goes down as we get closer to a flexed knee. Same thing with squatting. As we get closer to a straight knee, there's more strain. So a mini squat to about 40 degrees has about 2% strain versus, open chain knee extension has about 2 to 4% strain. So when we say let's not do open chain knee extensions, why, if we're having people do squatting early on? So it doesn't make sense. Hasn't made sense. Papers that are out there now are showing it's safe to do open chain knee extension. There's no strain on the graft. There's no change in the length of the graft, or no stretching out of the graft. And so I say we tend to wait a couple weeks. I do 90/40 for about 2 to 4 weeks just to kind of get the quads going, not irritate the front of the knee, let the incision close. And then I am really pushing them through full range of motion, 90 to 0 knee extensions shortly after that, with ankle weights and then knee extension machines and things of that nature. We do a lot of BFR after surgery, blood flow restriction training. Numerous studies have come out. It's safe. It's safe for most populations. Understand what the contraindications are before you use it. Educate the patient on what it is, the effects of it. Really good modality to use. I tend to wait 2 weeks out of surgery to incorporate BFR in my patients, let the wounds heal, let the knee calm down. Some people do it earlier. That's up to you. I tend to wait 2 weeks. I'm doing stim and biofeedback early on, but BFR is a great modality to incorporate. You'll get proximal, distal, contralateral effects. You would think it's the greatest thing since sliced bread, but I do use it. I use it for all my ACL patients as long as they can handle it and they don't have any kind of comorbidities that would not allow me to use it. So, it's a huge thing that I've incorporated into my practice. Up to 80% limb occlusion pressure. Strength tested with a handheld dynamometer into a table. BFR group has significantly greater strength at 6 weeks. Yeah, sure, whatever. It doesn't replace strength training. So I use BFR from probably 2 weeks to about 6 to 8 weeks out of surgery, and then I kind of put it aside, and then it's just raw strength training after that. It's just working on squats, working on single leg squats, just working on knee extensions, working on lunges, lateral lunges, all that. Load weight, play with reps and sets, periodization, old school strength and conditioning. Can't be replaced. You need that stimulus through the tendon, you need that stimulus through the muscle that you don't get with BFR. So BFR has a place. For me, it kind of runs its course by about 8 weeks or so, and then it's just raw strength training after that. Okay, but there is a lot of research that shows improvements in cross-sectional area of the muscle, and proximal gains and stuff like that. There is some kind of systemic response from it, so highly recommend it. I use it again with my patients. He had an ACL, baseball player, knee extension machine, a supine, quadriceps lengthened position with the towel around his knee. He can work on knee extensions that way. And then this is for my quadriceps tendon grafts that I want to focus on the hip in a relatively extended position. You can see she had, where is it? A quadriceps tendon graft and an LET. She's actually my current patient right now. And I work on a hip extended position where we're going to get the rectus femoris more engaged, because again, when they take that quad graft out, they're taking a lot of that rectus tendon. So if we're working in a seated 90-90 position and working on quad strengthening that way, that's a shortened position of the rectus. The rectus is not firing as well. You're not getting the full quadriceps muscle engaged. You got to put them in a somewhat hip extended position, relatively hip extended position while they're doing their exercise. You can see we're using a continuum 2 unit, so stim on the quads while she's in this position. Again, once you start open chain stuff, I talked about that. I should have slid this slide a little earlier. Sorry about that. But Farelli out of Europe has been leading the charge. Great researcher, and has really met my biases in doing, open chain knee extensions early on, no changes in joint laxity, and good strength after doing it. So highly recommend doing it. This is a paper that came out, oh, I guess it's 2023 right there, right? Okay, perfect. The cross bracing protocol. So Dr. Cross, that's it's named after him, determined that in a group of people, the ACL can heal. I'm very skeptical. Um, it's the research needs to be replicated by independent groups. The re-tear rates in some papers are about 70%, but the protocol has to be implemented immediately. And so what we're talking about is somebody tears their ACL. It's determined that the tear is proximal, so it's on the femoral aspect. It's not a mid-substance tear. They put the knee in about 90 degrees of flexion for about 4 weeks, and they hold them there. No PT, no motion. So they're locked in a brace for 90 degrees. They have to go on prophylactic medications for DBTs because the leg is not allowed to move. And this study, an early study, showed a 90% healing rate just by MRI. So we're not looking at any kind of second look arthroscopy. So again, somewhat skeptical. It is out there, the cross bracing protocol, implemented immediately, proximal tears, immobilize them at 90 degrees of flexion, and then slowly work on motion after that. We'll see. I'd like to see this replicated in other independent groups that can do this. So it's encouraging, but there was no control group, and a lot of people needed to go back in and have their ACL reconstructed eventually. So we'll see. But I just wanted to mention that as it's an option that's out there. It's big out of Stephanie Filbay is out of Australia, and so keep an eye on her group as well to work her magic there. AMI, arthrogenic muscle inhibition. This has been a hot topic in the ACL world probably the past 5 or 6 years, especially. You go to CSM, combined sections, APTA's big meeting, and there's a gazillion talks on this. Highly important to understand. It's kind of hitting upon why the quad has difficulty coming back, right? There's a muscular function activation issue that is occurring. It's very complicated, but it seems like there are some modalities that are out there that potentially can help restore the quads a little easier if you implement them somewhat early on in the recovery process, right? There's moderate quality evidence that shows cryotherapy, so icing the knee for about 20 minutes prior to exercise may help with arthrogenic muscle inhibition. Exercise itself obviously has very good evidence. A hamstring fatiguing protocol. So a lot of my patients that are struggling to get their quads back, I'll just put them on their stomach and do some resisted hamstring work. And that seems to help with quadriceps function. Vibration therapy too. This is full body vibration therapy. I tend to just extrapolate a little and I don't have a full body vibration platform, but I'll just take like a Theragun or some kind of vibration gun, and I'll just do a quick pass along the quads. Don't be aggressive and think more is better. You'll kind of desensitize them, and they won't have as good quad function. But I think some vibration therapy as well has had some pretty good quality evidence as well. So kind of keep that in mind too, because it's out there, and we know the quads struggle to come back, especially in certain graft choices. And so you have to implement exercise. We do cryotherapy, yes, but I brought it back in early on in the session. That person that's 12 weeks out of surgery, I'm doing ice before the session. I used to heat them or just throw them on the bike as a little active warm up. I'm icing them and then they're doing their session. So little things like that. Oop, I wanted to mention. No, that was good. So again, ice, vibration therapy, things of that nature, right? Ultrasound. So this is one paper, but we talk about how ultrasound's bad. PT school says ultrasound is bad, right? But we want to keep this on the down. It's our secret, right? Ultrasound, so pulsed ultrasound versus non-thermal versus sham helped with AMI. Uh-oh. Right? So just keep that in mind too, that the hatred towards ultrasound, there was a paper, Grant Nort, who is a big researcher on AMI, did show this in 2015. So, and also biofeedback, right? I think biofeedback is huge. I took this video literally like 4 hours ago in our clinic. This is using the M-Trigger device out by Russ Payne, and our friend Russ Payne, who just recently passed, and friend Brian Pryor, who put this out. Great biofeedback device. She had a right ACL reconstruction 3 years ago and a left ACL reconstruction last year. Still, you can see her right quad. She is a strong girl, field hockey player at Cornell, and using biofeedback has really helped to get that quad to come back with her. So there's games on there to kind of act. It's almost like that neurocognitive overcoming AMI thing. And so using biofeedback to me has been a huge addition, along with STIM, along with BFR, in helping to get overcome that AMI and get the quadriceps function back. So the M trigger device, and then just good old fashioned strength training. I took this video yesterday. Load the non-surgical side. So this is my ACL patient. He's in a band. That's why he looks like that. Just kidding. Love you, Danny. But loading that right side, right? He's holding a heavy kettlebell, loading the right side while he's also working the left side, the surgical side. So, the left video is his good side, cross education. We want to load that right side, but also we're loading the left side. And you can see I got the weight in the opposite hand of the leg that's involved. I want to get that hip involved too. And then, sissy squats or whatever, call them wall squats. I want that knee over his toes. So again, loading the patella tendon, loading the quad is huge in these patients. So again, monitor anterior knee pain. I monitor his knee before and after each session, critical. And so these are little things that I do because we it's tough to get the quads back, and that anything we can do to decrease re-tear rates is going to be critical. And the neurocognitive implications that Dustin Grooms and Meredith Chaput and others have talked about, go see a talk by them at CSM. It's a huge thing where our brains are basically rewired, so to speak, that we don't use sensory input. We're relying on our visual input to coordinate our movements after an ACL reconstruction. So a lot of what we're doing after the surgery is working on re-implementing that somatosensory input that they need to get back on the field, right? When you're going to catch a football, you're not thinking about, I got to take a step, I got to take a step, I got to get that knee into an extended position, I got to slightly flex the knee as the football. No, you're just thinking about catching the football. You're thinking about, catching a lacrosse ball and, chucking it at the goalie. You're not thinking about, I need to get my knee over my toe to engage my quad or blah, blah, blah. You need to create this in the early PT stages, right? Working on different hops, working on they're doing a math problem while they're doing some kind of coordinated movement. You got to take their mind off of the task that they're doing, let them perform the task while they're doing something else, catching a ball, catching some kind of frisbee or whatever you have. Get them to do it. That neurocognitive activity is huge to rewire their brains to get more of a somatosensory input implemented and not a visual input. Don't have them look at their knees while they're doing a quad set. Put a towel behind the knee, squeeze that towel down into the table, or use the M trigger, use the biofeedback device where they are looking at a scale to see how much force they're producing and not looking at the quad muscle itself. I'm giving him cues where it's opposite. Maybe I put my right hand down, he's going to move to his left, blah, blah, blah. So it's throwing them off. It's having them have to think a little while they're performing a task. We're running out of time. I'm already over time, but and also I do a lot of baseline testing pre-surgery. If somebody comes in pre-op, I want to get their strength right at time 0 when they just tore their ACL. So all my patients get tested pre-hab on the uninvolved side. I'm not testing their injured side. I'm testing the uninvolved side to at least get a baseline on what they were pre-surgery, post-injury, because this study showed that most patients are not achieving their pre-injury level at the time of testing, at the time of being cleared to return to sport. Only 28% of patients actually met that criteria. If we compared their current test with their pre-surgical score of strength testing, right? 57% actually achieved 90% LSI if you tested them. If you compare their current strength tests with their contralateral leg. So they're going to pass their test easier if you're comparing time now versus time right at injury. So I think it's more realistic if you get your doctors on board with prehab testing. This is how I do it. I use the Vol Dynamo. I do an isometric at 90 degrees. and they are kicking and pulling, some testing quads and hamstrings. We have some jump testing that we do as well. We use Evolve force plates. If you don't have them, that's okay. Get a relationship with a clinic that does, because we know that drop jump vertical testing and counter movement jump testing is highly related to quadriceps function, more so than a horizontal jump test like a hop test, the old school hop test. So I tend to lean more on these tests than the old school hop tests that are still out there. That you have here, the single leg central reaction hop or peripheral, all these tests that are still being done. So, in our ACL patients, we need to obtain knee homeostasis, calm the knee down. First and foremost, get the swelling under control, get the pain under control, get some hyperextension in the knee, compare it to the other side, make decisions based on the other side, progressively get their range of motion back, respect the healing tissues. Again, it takes 2 years for that ACL to mature. So, don't rush it. There's probably some kind of bone bruise involved. And then you got to be a good strength coach with these patients, because they could be under your control for 6, 9, 12 months. And if you're not, fine, find a strength coach that can handle your patients, or hire one, better yet, and keep them in house. And because you're going to have to be able to periodize them and work on strength, power, endurance, agility. You're going to be able to test this, retest this. There's so many things out. Gym Aware has some velocity based stuff that I didn't even talk about, or other devices that are out there for velocity based stuff where you're working on more power versus strength in your athletes. And that's all periodized in the program. So I don't expect a PT to understand all this. Fortunately, us a champion, I have 6 strength coaches that I talk to, work with, and that my ACL patients end up going with further down in the process, that we compare notes and get the patients back that way. So you don't have to do everything, but you need to be able to get the basics really good early on for the first few months. Okay. So that's it. I think that's all I had. You can find me on social media. I'm on, I guess I got to update that slide. Twitter is now X. I'm on Instagram if you're interested. Um, I have some courses on MedBridge. If you know MedBridge, an online continuing education platform. And Mike Reinald and I have an online knee seminar as well, where we go into big details on ACL rehab. That's at Mike's website, MikeReinald.com. OnlineKneeSeminar.com can get you there as well, but you can search Mike's courses as well. So Mike and I have a course, and then again, like I said, I have MedBridge as well. So all I got, Ben. I'll kick it back to you, and if there's any questions, I'll do my best to answer them. So yeah, thanks,
Good
guys.
job. Thank you. Yes. And for all those who are on, the chat feature is where you're going to put your questions. So feel free to get in there and begin typing questions so that we make the most of the next 7 minutes. And I will actually kick it off. So you mentioned the pre-testing with the contralateral limb. Do
Yeah.
you do the same test battery for return to sport, or is there more to your return to sport decision?
When I have somebody come in pre-surgery, post-injury, I am basically looking at their baseline stuff, looking at, is the knee, how's the swelling, how's their extension, how's their flexion. We got to establish that. If they're somewhat pretty good, it turns into a strength training program. Just let's not aggravate the knee, but let's get, maybe some leg raises, but maybe some, mini squats, wall squats, quarter squat, something like that. I'll also do with the dynamo knee extension and knee flexion testing. And I'm looking at on the uninvolved side, the non-injured leg, I'm just looking at their baseline strength. So I have that when I first start testing them 3 to 4 months out of surgery. I'll see where they're at. And you'd be surprised, a lot of people that if they are, I know that Epic study showed a ton of people couldn't match their pre-surgery numbers, only 29% did. I'm seeing people blow through those pre-surgery numbers. They get a ton stronger just by the dedicated rehab that they do with us, where that baseline number that they were at, that pre-injury, pre-surgery, post-injury number that I got, they blow through that. And so it's good to have it as a baseline. I guess some of the older people who don't really work out, it was a skiing injury, but they're not dedicated to working out, they sometimes struggle to get to their pre-injury number. But have that pre-injury number as a rough gauge, and you better get your athlete way past that number, 6, 9 months out of their surgery.
And are you doing functional test batteries to help with the return to sport decision with
With the
the
return to
physician,
sport.
the athletic trainer? Yeah.
Yeah, we are. I mean, we're doing, like I said, drop jump testing, double leg, single leg. We're doing counter movement jump testing, double leg, single leg. We have timing gates, so they're working on a 5-10-5 or 5-0-5. Trying to think what else we're doing. It's always evolving. Um, that's basically it. So we have the knee extension, knee flexion. We have counter movement jump, drop jump, and we're looking at different parameters. They're braking, RFD. We're looking at symmetry, obviously, and the double leg stuff. Are they still leaning 20% or so onto the uninvolved side? Are they more symmetrical within 10% or so? What's their concentric forces? What's their eccentric forces? What's their braking forces compared? And so all that is taken into account, and then they get cleared to begin to do field stuff. So that's just to get cleared to start doing field stuff, and then I
Yep.
kind of hand off to the athletic trainer or whomever, a coach, some kind of whatever ski coach, lacrosse coach, whatever, and hopefully talk to them, or at least talk to the athlete and say, this is what I think we can do. Let's do predictable field stuff where you've got a lacrosse stick in your hand and you're running and you're shooting. All right, let's do some unpredictable stuff. Maybe you're doing some one-on-one but no contact. Let's add in contact after 2 or 3 weeks of no contact and slowly layering stuff on. And then, all right, let's play 5 minutes in a scrimmage game. Let's do 10 minutes in a scrimmage game. It's this huge process once they finally get
Right.
cleared to field stuff that they are still going through. It's a lot longer than we think. So
No, I
yeah,
love that approach too. And you mentioned it in your initial sort of outline of the program and certainly all over social media, this real necessity to focus on criterion-based return to play, not time-based or
yeah,
even straight up numbers based. You really
yeah.
have, it's such a complex
It really is.
decision to do it the right way.
And I didn't even talk about any ACL RSI stuff. I tend to not use a lot of subjective questionnaires. I think my athletes lie. I think they want to get back. The ones that I know are fearful, I may give them an RSI or some kind of test, or you just kind of know they just mentally they're skittish. They're not ready. They still don't feel like they move well. They kind of hinting to you that they don't know if they're ready. But you can use RSI scales or Tampa scales, stuff like that, to kind of gauge that and see if there's a progression in their, I guess, fear factor and how they feel about their own knee and returning. And that's a great way to, be able to have an excuse to not get them on the field. They just don't feel ready. So, those little tricks out there as well you can use if you're looking for an excuse to hold somebody back, because the coach is going to look for an excuse to bring that athlete back on the field. And if you get them back too quickly,
Yep.
it's doom and gloom. It's just not worth it. And you gotta from the beginning, I'm talking to the athlete and the family about that. And let's not rush this, because you'd be surprised. 7, 8, 9 months out of surgery, they
Yep.
forget that conversation happened, and they're trying to
Yep.
push things along quicker than they should be going. You're like, guys, listen, we talked about this. We're not getting you back. We're gonna use the data. I'm gonna watch you move. There's so many different factors. How's the knee responding? Is your knee still swelling? You still have
Yep.
some knee pain. There's so many different things that are going. Is it your freshman year in high school, or I mean, freshman year in college, where you could get a red shirt? Why are we trying to rush you back? Let's
Yep.
take the red shirt year and have you maybe play in the summer and get ready for fall of your sophomore year and take the red shirt. So you probably weren't going to play anyways, a freshman. Why try to rush back? And so there's so many
Yeah.
different little tricks that I use to try to motivate and or bring a realization that what really has to occur. But you got to set the stage early, and you got to throw carrots to them too. You got to talk everything out to the families, to the athlete. Outline
Yeah.
stuff. Have monthly goals. All right, this is what we got this month. I'm not always adding exercises every session where they just keep layering and layering stuff on. This is our month block. Our month block is to focus on, strengthening. Or this month block, we're going to focus on power production. This month block, we're going to work on strengthening plus agility stuff. So I'm always kind of, it's a month by month process for me. It's not a session by session, always progressing people.
That's great. I really like the neurocognitive element that you brought up as well, because to your point, when you've got them distracted on other tasks that seem unrelated, you're going to get a
Yeah.
better sense of
Yeah. Yeah. Yeah.
their subconscious
Yeah.
confidence in
Right.
that limb.
Yeah, you get to see how they truly move, and you're like, "Ooh, okay." I think
Yeah.
you're not going to say that to them, but you know what you need to do to hopefully adjust. If not, you talk to somebody and make the adjustments. Yeah.
Yeah. Well, fantastic job. We've hit 9 o'clock. We have no additional questions in the chat, but absolute pleasure. If you don't follow him on social media, definitely do. Check him out at TSN. Really, really appreciate your time and expertise. Thank you
Yep.
for contributing to Residency Hot Topics. And for all that are watching and who are watching the recording, we will see you next time.
All right. Thank you.